healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI by breaking things down into language you can understand. We create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. Today, we'll be talking about hospice and palliative care with Anthony Young, a newly minted nurse practitioner coming to us by way of New York. This is a really special episode. We think it's an important topic. We're actually airing this during October, Breast Cancer Awareness Month, and it's just another addition to a series that we started in October 2023. During that month, we shared the journey of a couple people, one of them including my mother, Reverend Leona Madison. We broke her journey up into different phases: the diagnosis, treatment, and life after treatment, as well as an episode dedicated to faith and medicine. Then we were honored to have Dr. Dawn Mucci, who is a physical therapist, share her journey as the daughter of a mother who died from breast cancer, as well as Paris Lee and Lori Lee on two other daughters who also lost their mother to breast cancer. We invite you to check out that playlist. And we want to thank everyone who participated in our breast cancer awareness this month. We shared them on our platforms and their stories, and you're going to hear more from them in the new year. In today's episode, we're going to talk about the difference between hospice and palliative care, what makes them similar and different, the roles nurses can play, common misconceptions, and we have some advice to share with clinicians on how you can make that conversation a little bit more comfortable and gain more education to increase your confidence, because even if you're a clinician, it can still be a really difficult conversation to have sometimes. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner and one of your co-hosts here at the Melanin Initiative, along with Alicia and Geraldine, who send their love in their absence. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and then to use it to manage your health and advocate for others. It's our hope that by watching on YouTube, LinkedIn, now Facebook, thank you so much, or listening on any of your favorite podcast apps, that you'll feel empowered to ask questions, educated on how you can manage your health, and confident to navigate the healthcare system. That was our motivating goal for starting this show. Through the show, we've grown, right? And so we have two missions now. The second one is to elevate the voice of nurses. And we do that by showcasing their expertise, like we're going to do here today with Anthony, who has decades of experience when it comes to hospice and palliative care. Many people enter healthcare because, for one, it's one of the top 10 industries in the country. It takes up the greatest percentage of the GDP. And it has a lot of job security, and a lot of people are just out here wanting to help someone else. So they might enter healthcare as a first career straight out of high school, or second, third, fourth careers. We know that there are people all ages entering healthcare for the very first time. And we just want to be able to provide a point of reference, share people's journeys and stories so that you can have a better idea of what it is you're getting into, how to get the support you need, and expose you to all the opportunities that exist beyond being a nurse and a doctor. While there are great options and professions, there's a lot of people that make this industry go, and it might just be a great fit for you. If you haven't already, please subscribe so you can be notified when we release new episodes. You can find us on every social media platform and any of your favorite podcast apps. Please take the time to leave a comment or two, rate us on the Apple and Spotify podcast. It lets the algorithm know that this information is important, so that when people like you look for information like this, we show up higher in the search results. Remember, this show is for educational purposes only. The opinions expressed here are opinions alone. They are not a representation of any of our affiliations. If you're experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. And if you or someone you know might be having a mental health emergency, you can call 988 or text 741-741. Anthony, welcome to the Melanin Initiative.
Thank you. I'm happy to be here on this Sunday afternoon. Thank you.
Yes, thank you so much. Before we get into the difference between hospice and palliative care, we just want to hear a brief story about your nursing journey.
So, nursing journey, that's a good question. So I was inspired to become a nurse by my grandmother, who was a nurse in the ED. So I'm originally from Washington, D.C. So she was my initial inspiration. So I decided to be a nurse. I got my bachelor's degree from University of Maryland School of Nursing. My clinical background is primarily in oncology. So I started out in bone marrow transplant, which is on patients who have blood cancers such as leukemia, or even patients that have lymphoma, multiple myeloma, et cetera, and providing chemotherapy for them and their treatment through that process. I've been in several roles over the 23 years that I've been a nurse. So oncology, I've been in leadership roles, nurse education, a lot of places that I've been. So I've definitely have had a fulfilling and fruitful career. So I'm excited to be here to talk about hospice and palliative care.
That's wonderful. And you also represent a small percentage in the nursing workforce, right? You're a male and you're Black, and
Yes.
you've escalated up the ladder both professionally and in academia. And just last night, there's a group called Brother who
Yeah.
just started, and they had their first kind of meeting, and their whole goal is to increase more support amongst Black males in nursing. So shout out to them. And I think I tagged you on there so that you all can link up and
Oh
collaborate.
yes. I was on last night. So yes, I joined the actual group when it started December of last year. So thank you so much for being present and supporting. So thank you.
Anytime. Yeah, I think it's great that you guys have a safe space. I was honored to be allowed to be part of that. And any way we can support you all in your mission, we're more than welcome to do that.
Thank you.
All right, let's talk about the difference between hospice and palliative care. So how do you describe hospice to your patients?
Hospice is care that's provided at the end of life. So two physicians have to certify that this patient, based on their disease, has 6 months or left to live if the disease takes its natural course without any further treatment, et cetera. So then those two physicians have to certify that. And then obviously that person can then be enrolled on hospice care, which is a Medicare benefit. So then those patients will receive care either primarily in their home, or it may be in a facility such as a nursing home, et cetera, just so that that person can be comfortable at the end point of their life. Again, the distinguishing factor is the last 6 months of their life.
And I'm curious, is that a state-based, the two physician rule, or is it two providers?
So as far as I know, yes, that is, it's two physicians throughout the country that have to certify those individuals working in hospice, et cetera. We do have nurse practitioners who are on the team, but it still has to be, right now, according to regulations, it has to be two physicians that make independent assessments about the patient's status and then determine if this patient is eligible for hospice based on their disease.
Okay, wonderful. And what's the difference between that and palliative care?
So another good question. So I did a presentation this summer at the National Black Nurses Association conference in San Francisco, California. And I learned the statement I'm about to make, I learned from my instructor in my palliative care program at New York University, Dr. Dorothy Houlihan. So all hospice care is palliative care, but not all palliative care is hospice care. So when she first mentioned that to us, it was confusing, but it makes sense. Many people get it confused that, okay, if I'm on hospice care, I'm about to die tomorrow. And then if someone introduces the conversation about palliative care, I'm about to die. So everyone has that misconception, and the words are sometimes used interchangeably. So then that's what has led to there being some confusion in regards to palliative care and hospice care. Yeah, so it's not a thing where you're diagnosed and you are put on hospice care and you're going to die tomorrow. Just think about President Jimmy Carter. He's been on hospice care for over a year. So definitely it doesn't mean that you're going to die the next day. It just puts you in a place where you can take advantage of the Medicare benefit.
Good point. Yeah, and even with the two physicians and the calculations that they make and the prognosis, even then, even that is still an estimation and we don't know. But like you mentioned, it helps you get access to other care because perhaps the goals have changed, right? If we're no longer looking to reduce your risk of blood pressure or, resolve your kidney failure or insufficiency, and our whole goal is really focused on comfort, nausea, GI, then you might have, and pain and sleep, right? Then you might have better symptom management response and
Exactly.
access to things that maybe primary care doesn't normally do or feel comfortable with. And like you said, there's lots of examples of people who have been on both palliative and hospice care for years. And then sometimes people go on it and then change their mind and come off of it. Now, we don't want that to be like every other day you're changing your mind, right? We want you to be well informed so you can make a really sound decision, so that the patient or yourself can get the care you need. Because every minute that we delay that decision, you're either suffering or the costs are going up, your stay is increasing. All the things that we're doing that might be invasive and just worsening how you feel continue until those decisions are kind of made.
Exactly.
And so what is the criteria for palliative?
So palliative care can be someone, say, for example, they have a serious illness or a life-limiting disease. So you may see a lot of those words out there, but someone with an advanced serious illness, such as chronic kidney disease, or someone that has heart failure, those types of things, they're not dying tomorrow, but maybe they just got the diagnosis last week. So then with palliative care, what you're wanting to do is starting that conversation. So you talked about it earlier in regards to goals of care. What do you want done? Who's going to make decisions for you if you're not able to make decisions yourself? So having that conversation and talking about what you want. And it's very difficult because many people hesitate to have that conversation with themselves first, and then obviously with your loved ones and your friends. But that's very important. So palliative care just starts that conversation, and then looking at, okay, what medications are you on? How can we support you better in regards to not only managing your symptoms, but how can we support you from a mental standpoint? So there are other individuals on the palliative care team, such as a chaplain, maybe a social worker. Some institutions may also have a psych mental health nurse practitioner on their team. So it's an interdisciplinary team that works with the patient and the family to make sure that they have what they need at that stage of life. So again, starting that conversation, getting that support is very important at that stage.
Yeah, and I think, in healthcare, we haven't really done, we've done a disservice to the public because we bring it up too late. And you just mentioned some diseases that we already know the course of. And so the minute someone gets diagnosed, that's really the ideal time to talk about it. And you might be 40, you might be 50 with 20, 30, 40 more years to live. But because we know maybe this disease doesn't have a cure, or we know that it's going to progress at a certain rate, or we know your risk for certain things are going to happen, we want to make sure you have the care and the support. It's not just medications.
Yes.
It's actually like medical devices, access to the specialists that you just mentioned, so that you're not struggling and surprised when these things are actually happening.
Definitely. And definitely the support of the caregiver. A lot of times the caregivers are lost in the sauce, because then the focus is just on the patient, but making sure that the caregivers have what they need, because it's hard work. Just think about the work as nurses that we do when we are providing care to our patients. But then you have a family member, be it a mother, father, sister, or brother, who may not even have a medical background, and having to deal with the emotions of it all, but then also providing a physical care to that individual or supporting them. So making sure that you're providing support to the patient, also whoever's in their network.
Yeah, based on my experience in the last year, I would say, and it's not like a surprise, but that caregiver might be the most important person on the healthcare team. They provide information. You just mentioned it's a hard job for nurses, but we clock out.
True. Yeah, that's true.
Even as the provider, I have boundaries, when I'm not answering the phone, I'm not talking to people, but the caregiver, they do not have that. And physical demands, almost all of them end up with some kind of back pain. Sometimes a lot of times they have to take off of work. So you're talking about a hit to their pocket. A lot of times that patient was the primary breadwinner. So now the caregiver is figuring out how to be present and advocate for their loved one, but also how to pay the bills. Where does this money go? Who do I call? Like, it's very stressful. Taking care of little ones. Maybe you're also taking care of a lot of people. They're taking care of older parents who might be dying or in hospice. Sometimes they have had surgery or need to have surgery. So then it's like, okay, well, I'm taking care of myself and I might be out. Who can take care of me and who can take care of my loved one? Well, it's a lot of decisions, and there's no playbook. There's no rules on how to do it. And the only thing they want to do is make the right decision. And sometimes that's really challenging because you've never talked about it. You might maybe the person hasn't disclosed their medical history, so you had no clue that this was even an option, a possibility, or maybe they just haven't been comfortable, or they, we like to live for a long time thinking that we're invincible and that these things are never going to happen. And it's just not true. Or maybe you've had to work so much that you haven't had the time to really take care of yourself. There's a million different things, social determinants of health, that come into
Yes.
play, health literacy, that can make why those conversations haven't occurred. And I think it does come back to the fact that sometimes we wait too late to introduce that conversation. So automatically people think I must be dying and you haven't been honest with me about my condition. And that's the only reason you're bringing it up. And I think a big distinguisher between hospice and palliative, for hospice, it could be deemed like terminal, right? Right now we're talking about breast cancer in October. So it
Yes.
could be any kind of disease that has been deemed incurable or terminal. We've tried a million things, it's not going to get there, or it's so severe we don't have really enough options that make it medically ethical for me to even continue to recommend other treatments. But it could also be the patient. Maybe they've decided, I don't want to live like this. I don't want to keep having infusions. I don't want to keep going to these appointments. I don't want to be in these sterile environments. And a lot of people just say, I'm going to die anyway. They've lived a long, good life and they want to be home, living the life the way they want to.
Yes. I wanted to also make another distinguishing point between hospice and palliative care. So with palliative care, you will still be, in most cases, still getting treatment to cure that disease. So if it's breast cancer, you're still getting chemotherapy. When you make the decision and you transition to hospice, and then you go through that whole process, is certified between two physicians, then that curative treatment stops. Thing is, you've made that decision, and we make sure that you are involved in that process, the process of shared decision making, et cetera. So that's very important. That, okay, palliative care, I'm still getting curative treatment for my disease, and then going to hospice care, a conversation should have been had to say what's the risk versus the benefits for that transition, when then you won't be getting that curative treatment. So that's another distinguishing factor between hospice and palliative care.
Yeah, that's wonderful. And also the focus is really like on on the symptom management too, right? And sometimes I think we haven't done a good job explaining to the public why we're no longer going to do maybe this IV hydration or this artificial tube feeding, or manage that blood pressure that we told you was so important to take that medication for such a long time. And now we're saying, oh, it's not really important anymore. And so that can be confusing to the public. But like you said, and that's why it's so great to have that palliative team on board, because the
Yes.
nurse is busy, but palliative care, they have the time to sit with you, to take the time to answer your questions, to talk to the whole family. And they do it every single day. So they're experts in that field. They're going to answer questions you don't even know to ask.
And then when you're talking to the patient, because sometimes, in putting myself in the shoes of the patient, if someone's communicating to me, say that we're not going to do this, we're not going to do this, we're not going to do this, it would make me scared too. So the way that we frame it is that we're providing support. So our conversation is led with what we're providing, what resources, symptom management. Yes, the reality is some things we're not going to do, but that conversation should be led. Well, how is this adding benefit? How is it supporting my life? Because then if I lead with that, we're going to stop doing this, we're going to stop doing that. Me too. I would say, okay, well, I don't want to do this. So we always have to lead with the value that we're adding to your life and to your care. And then obviously still have those conversations about, be it those medications or treatments that may not be useful at this point. But again, the patient still has the autonomy to make that decision. So we definitely having that conversation is important.
Excellent. And you mentioned two vocabulary words. I want to make sure I just address those for people
Yes.
who might not be familiar. Earlier, you mentioned oncology. That's the name of people who specialize in cancer treatment.
Yes.
And then you just mentioned autonomy. That is you being able to make a decision by yourself, well informed, but uncoerced.
Exactly.
So
Yeah,
just
thank you.
make that clear. And so, what's the role that nurses can play when it comes to palliative and hospice?
So good question. So nurses, you have an RN, a registered nurse, who may be providing the day-to-day shift-related care to that patient, doing an assessment, giving them medications, etc. So you have the RN, and then you have other team members, other nurses who are nurses, but they're trained at advanced level, be it a nurse practitioner. So the nurse at the bedside is very critical in the sense that that nurse will be able to identify any acute or any changes that have occurred recently or currently with that patient, and then communicate that to the nurse practitioner or communicate that to the physician. So it's an entire team process. Even within the world of nursing, you have the RN and the nurse practitioner who still are working together to make sure that the care is provided to the patient. So again, having that RN at the bedside, being able to provide the bedside or the chair side, because thinking about, I was an infusion nurse too, so we're at the chair side, just to put that in there, that we can see those acute changes or rapid changes in the patient, communicate that appropriately to the nurse practitioner or to the physician, and making sure that we're meeting the patient's needs and managing their symptoms.
And for any viewers who don't know, when you get that chemotherapy or at that infusion center, it's a nurse giving it.
Yes,
Right?
yes.
And when you're in the hospital, these are nurses administering it, whether it's IV or by mouth, and they have taken an exam. Some of them have gotten certified to be able to do that sufficiently.
You know, we go through a chemo and biotherapy course. I've done that several times. So it gives us the knowledge and the skills to learn about the medications, the disease process, so that when we are giving the medications, we can make appropriate assessment and then give the medication safely. So yes.
And then you mentioned the infusion nurse at the chair side. And my mom said, because she did chemo and but she kept going to that oncology center for a long time. I should know the numbers, but she just graduated from there like 2 years ago. So it was still a long, like because she was taking like tamoxifen for a long time. And so she really just stopped seeing that team maybe a year ago. And so even though she was diagnosed in 2012, so and this is 2024, but I mentioned that because it was the same nursing staff, and so she would just call, they would recognize her voice, and so even though you're happy to get away from oncology care, she still had such a great relationship with them that she, even it was kind of like a grieving of like missing those people who you really came to trust and depend on.
It's a family, because being an infusion nurse, those patients are coming in, especially after they get treatment or while they're going through treatment, they're coming in every day, checking their labs, doing an assessment of them. So you see them every day. So you develop that relationship, that connection with them where they trust you. You've established that trust. You've gained the trust with that individual and with their family too. So then that can definitely be a difficult process when you graduate and you're done with treatment and you don't have to go as often. That, okay, I've been so used to going every day. I get my lunch and stuff prepared. I get my things, all this together, and then it just slowly goes away. And that's a good thing, because we want you to graduate, because we know that your treatments are working and things like that. But it can be a difficult process since you've made that connection with those individuals.
Yeah, we want to also shout out the nurse at the home, right? Because when you do get palliative or hospice, it could be at home that you're getting additional services, which is why we are even having this conversation. We want you to know that the hospital is not the only place for you to get the care you need. And that when your disease or you decide that you've gotten to a point, you don't want to keep going back to the emergency room, waiting in the waiting room, getting poked, getting x-rays, sitting in incontinence, going through pain, not getting the medications you need, all meeting a new team, having difficulty of them communicating and coordinating care, being ready to get discharged, sitting through in the ambulance, the cost of all of that. When you get tired of all of that, sometimes you just want to get care at home. And when you find out that a lot of it could still be provided at home, it's a lot of people are really excited to hear about their options, and they're just options. You don't have to agree to anything. It's just so that you can hear it. And if you're not ready at the time of that conversation, but maybe in 6 months you're ready, we're certainly happy to revisit that. And now you're well informed. You're going to hear it for a second or third time. And now your confidence has gone up. You're more comfortable with it. You realize everyone there has your best interest at heart, that your care doesn't stop. It just changes.
Yeah, so good point in regards to the care at home. So again, the patient and the family is involved in that process, because the family will be caring for them. It's very important to know that the patient has that option to determine, okay, yes, I want my care to be received at home, especially from the hospice perspective, because I've had patients who, I want to go home. That's where I feel more comfortable. Let me be at home. And then you have some patients who want to be there and they want to die in their home. but then some individuals who want to be there to receive care, but they don't want to be in their home when they die. So then it's very important for to have that conversation. So that's why, again, that dialogue is very important, because the team doesn't know what is not communicated to us, but then the team has a responsibility to ask those questions to get a better understanding of who you are, what your wishes are, what your goals are, so that we can make sure that we put those things in place. So if you don't want to die at home, we can make sure that we have a plan or a process in place so that that doesn't happen that way. So the whole goal is to support what your care plan and what your needs are.
Yeah, because if you die at home and there's still people who live there, they will live there after you're gone, and they will have that memory of you dying there. Some people find that very comforting, and
Yeah.
some people do not. And so I'm so glad you brought that up. And it again just comes back to that conversation and deciding what is going to be best for you and your family. It's a
Yes.
great transition when we talk about conversations. Let's talk about the Conversation Project.
Yes. So the Conversation Project, it's a website, so you can go on it. It says The Conversation Project, where it gives information to you. It gives information to the layperson on how do I need to have this conversation? What documents do I need to have in place? Those types of things. So it helps in that process of talking through your advanced care plan documents, your living will, et cetera. Who's my healthcare agent? Who's the person that's going to make decisions for me? How do I select that person? Because everyone will say, okay, I want to select my husband, my wife, etc. But it may not be your husband or wife. So it helps you go through that process of how do I select that person that is able to make decisions for me? Because if it's my husband, if it's my wife, I may be too emotional to make that decision at that critical time. So then maybe it'll be my brother or my sister, someone that may be able to make that decision. So there's a lot of resources on that website, the Conversation Project, that will guide you through what that process looks like, what the conversations are, and then you as the patient, the family, being informed so that when you go to your visits, you can ask those questions and speak up for yourself in regards to the care that you're receiving.
I think it's so important that you brought up that who's going to make my decisions for me. They can be medical decisions, they can be financial decisions,
Yes.
and there can be stipulations for when we go to them and we don't go to you first. So that's clear, right? Just because someone signs up to be your POA or health proxy or whatever the case may be, it doesn't mean you're no longer part of the conversation. That document will clearly state when and who should be part of that decision making.
Yeah. So in most cases, the determining factor is if when that person no longer, that person being the patient, no longer has capacity. So then there's assessment that has to take place to determine that, yes, this person doesn't have capacity to make X, Y, and Z decision. And then that's when it would transition to your healthcare agent or whoever has the power of attorney to make decisions. So once you sign it, and if you're still have capacity, you're still in your right mind, you can still make your decisions. It's only when that assessment is made that you do not have capacity, you're not able to make those decisions, that then it will then transition to that healthcare agent or the power of attorney.
Yeah, and we're evaluating or assessing that capacity every time we have an encounter, right? And so sometimes the patient is nonverbal, they're non-responsive, they're non-participatory. That's an easy one to say, okay, they don't have any capacity. But sometimes they're walking, they're talking, they're feeding themselves, but mentally they're not making appropriate responses based on the conversation. They can't clearly verbalize by not choosing something, or by choosing something, they can't verbalize the accurate outcome of that. And so those are other things that we take into consideration when we're determining the capacity to make medical decisions. They can be very boisterous, they can be loud, they can be 6 feet tall, standing over you, and still deemed to not have capacity. And that's a tough one for families, especially if that person is like a head of household role and they're talking, and especially with the family member, you're talking about basic things, the conversation's completely appropriate. But once it becomes a little bit more complex, and we're talking about medical things, and those answers are not appropriate, we really have to evaluate if they should still be making decisions, especially when we're talking about safety or harm.
And you made a good point in regards to assessing capacity. It's done consistently or done on a daily basis, because you can not have capacity right now. We come back the next day and things change and you have capacity. So that's why it's very important. And it's at the responsibility of the clinician or the practitioner to make that assessment. because those things can change from day to day. So definitely making that assessment is critical in the process.
And you mentioned a decision maker. It's not always going to be the person who has the best relationship with you.
Yes.
It needs to be the best person who can make a decision that's within your wishes. Because some people might want to hold on to you, but as someone who's been in healthcare for over a decade, I don't want to keep doing everything. And that might be hard for my parents to hear or to support. Whereas it might be easier for my brother or a really close friend to make on my behalf. And so as I've talked to my family, I might not have them be listed as the first person for those reasons, because after the decision and after I'm gone, they still have those memories to live with. And people do grieve whether or not they've made the right decision, especially if you haven't had the conversation. But if you've had it and it's documented, that's all people want to know, is that they did what you wanted.
Yeah, so again, and we've said it several times, having that conversation is important. It is uncomfortable. It does feel weird to have that conversation, because I remember having it with my nephew, because then he would be that next person and had to verbalize or say that, okay, I'm okay. I just want you to, I want to have this conversation so that you know. So you always have to have that conversation. It feels uncomfortable, but again, documenting that, verbalizing it to that individual who's going to make that decision for you so that they will know when that time comes, because it's going to be a very difficult time when that person is going through that dying process. And it's going to be hard to try to think through all of that at that point. If you can refer to that document, I had my conversation with my uncle, my aunt, this is what they wanted. Let's do X, Y, and Z based on that. It makes the process easier. It's still going to be challenging from an emotional perspective, but those decisions are easier if you've already had the conversation and it's documented. You just follow whatever the wishes are of that individual.
Perfect. Let's talk about 5 wishes.
So again, 5 wishes is a structured format. I actually started using that when I was looking at or going through my process of developing my documents, where it goes through various questions in regards to what are your wishes? What do you want done specifically? Who is the person that you're going to identify as your healthcare agent, or that person is going to make decisions for you? So it's a very structured way, because you may not know where to start. Well, where do I start? What do I put down? So it gives you, again, 5 wishes. You can go on Google, you can find that, and it gives you the template, and it goes through it very succinctly. It's about maybe 5 or 6 pages. So it's not very long. And then it just goes through each of those sections. You write it out. And then obviously you have to go through the process of getting the notary. So you want to make sure it's an official document. But definitely it helps to guide you through that process. So again, we talked about the conversation project. That helps with that. And then the 5 documents. And then obviously that's the question everyone's here. What are the resources? What are the resources? So then that's why we're talking about those resources, so that you don't feel like you're on an island somewhere and I don't know what to do, what to say, who to talk to. Resources are out there.
And where's the best places for people to keep these documents? Because we know emergencies happen when we least expect it.
So definitely with all of the different weather situations that are going on with hurricanes, etc., you want to make sure that it's in a locked box, but something that is waterproof, fireproof, anything like that. So any type of safe, or you may have it at a different location from your house, somewhere where it's going to be preserved if there's a fire, a flood, or whatever. So you want to make sure that you have it in a secure location, and then you tell the appropriate individuals where it is, so that by chance, if you're not able to communicate, then they know to go to X place to pick up the document. So definitely have it in a safe space where that it's going to be preserved. If there by chance is a fire, a flood, or anything like that, is very important where you secure the documents. And also making sure that you provide copies of it after it is executed. Provide a copy to your primary physician, your primary nurse practitioner, and all those individuals in your life who will need the documentation, so that they will know.
Great advice. And the best time to have these conversations and to fill out the document is always going to be now.
Yes.
Waiting for an emergency is not too late, but it is not always the best time, because of all those emotions we talked about. And for you, life was one way a few minutes ago, and now it's completely different. The mind shift for that and the decisions that we're going to be asking you to make is really, it's tough.
Oh, yes, it is. It's real tough.
Any last words you'd like to leave with the audience when it comes to hospice and palliative care?
Definitely just knowing the difference between the two. Palliative care is symptom management while you're still getting curative treatment. Hospice care is when two physicians have certified that you have 6 months or less of life to live. So they're two different things. So again, I'll state this, and I stated a few minutes ago, that all hospice care is palliative care, but not all palliative care is hospice care. So just knowing the difference between those two, and then accessing your resources, 5 Wishes, and then the Conversation Project, just going out to those various resources to start that conversation and refer back to as you're having that conversation with yourself, and then also with your loved one. And I say yourself because you have to sit down with yourself and say, what do I want? So
Yeah.
that then you can then clearly articulate that to your family members.
Beautiful. And you can be a role model, right?
Exactly.
Any advice for clinicians who are thinking that they might want to be in hospice or palliative care?
Definitely, you can reach out to myself on LinkedIn, Anthony Young. I can be a resource for you. And then there's several organizations, Hospice and Palliative Care Nurse Association, HPNA. So just Google. You can Google hospice and palliative care. Again, as I said, reach out to myself. Just if you want to get more information about hospice and palliative care, what it is, if that's a career move or career path that you want to take, or if you are in a place where you maybe have a family member or friend where you want to maybe get them connected to someone to have that conversation with. Another point that I want to make real quickly too is that also making sure that the primary care providers, be it primary care physicians and primary care nurse practitioners, feel comfortable having those conversations. In the literature, sometimes, well, not sometimes, in the literature, it identifies that those conversations are not had at the primary care level is not because the patient may not be comfortable, but then the clinician, the practitioner, be it the physician or nurse practitioner, may not be comfortable having that conversation. So definitely clinicians reach out to myself, access the appropriate resources online in regards to hospice and palliative care, and having those conversations is very important.
Wonderful. Thank you. Is LinkedIn the best place to connect with you?
Yes, because that's not the only place, but I go there more often than Instagram, etc. So LinkedIn would be the best place to reach out to me. Yes.
And we'll have all your contact below, as well as all the resources that you mentioned today. And so we just want to thank you so much, not only for the conversation today and for sharing your expertise, but for your dedication over the last 20 years, right? It's not gone unnoticed. We're so happy for you now that you've elevated. Now you're a nurse practitioner. Are you going to continue? Are you making any changes now that you're a nurse practitioner?
So currently I'm looking for a palliative care job. So I want to be in that space where I can make an impact in that space, but then also support my primary care colleagues in education and resources so that they feel comfortable having that conversation, because there's a small percentage of palliative care practitioners. So we can't be everywhere. So the goal is to provide that resources, provide those knowledge to all the primary care providers so they can start that conversation. And then if they need more specialized treatment or specialized conversations, then they can refer to the palliative care team so that we can then support them. And always remember, when you are linked to palliative care services, that does not mean that we are pushing your primary care team away. We're working with them very closely to make sure that we're managing you appropriately. So when you are transitioned to palliative care service, we are still working with your primary team just to make sure that we're all on the same page in regards to care management.
Wonderful. And when people reach out to you, will they find a book that you've authored?
Not yet. Not a book that I authored, but I have, with a colleague of mine, published an article in regards to health disparities in the realm of hospice care. Just communicating, that's a whole other topic to talk about, but access to hospice care for Black and Brown people, and how can we increase that access. One thing that we were able to identify that we included in the article is connecting with churches or those places where those individuals are and starting those conversations in that place. So again, the article focuses on the health disparities centered around hospice care, and then what can we do? Again, going to those places, be it the churches, to have that conversation about what hospice is, what palliative care is, etc. So not a book yet, but since you stated that, you just put it in the atmosphere, so maybe the book will be coming soon.
Yeah, and just send us a link to that article so we can link that as well. And when they contact you and you help them build their confidence and their knowledge base, do you provide like training?
Not at this point, not official training, but then you put something else in the atmosphere in regards to having my own business,
Yeah.
to be able to have a one-stop shop to be able to provide those services. So thank you so much for speaking that into the atmosphere. So that is to come to also the book and then the business, so that when people come, we can have a formal process in regards to education.
Yeah, because you have experience in every setting, so we can't let that go to waste.
Exactly.
And you can come back when those things are available so that we can chat about them
Oh,
further.
definitely. I'll be ready. I'll be ready.
Remember, everyone, you can email us your questions or show ideas to tmi.melanin@gmail.com. If you haven't already, this is your chance to still subscribe to our YouTube, LinkedIn, Facebook, every social media platform. Say hello in the comments when you get there. Rate us on the Apple and Spotify podcasts. It helps the algorithm see that this information is important, so that when people like you look for information like this, we show up higher in the search results. At the time of this filming, we release new episodes on Sundays at noon Eastern. They go live on YouTube, LinkedIn, Facebook, and Instagram. Shout out to Angie for all that hard work. But we drop the audio on your favorite podcast app at 5 a.m. so that the night shift can be the first to get something and not the last. And day shift has something to listen to on their way to work and maybe play during huddle. We'll put all our resources that we listed today below. We thank you so much for watching, and we'll see you next time.